Next, we're going to hear from Jackie Casillas, who's going to talk with us about communication with AYA patients.
Good morning, everyone. So as we were preparing for this talk today, on our conference calls, kind of two questions rose to the highlight for the goals of discussion. And one is, how can we as healthcare providers communicate better with AYA population to maximize their lifestyle and behavioral health across the cancer care continuum, and can being an active participant in their care during cancer treatment promote their active participation in health promoting activities as survivors. And really there's a paucity of literature in this area, but I want to highlight different studies that I think can lead insight to future research. So first, as we heard yesterday, there are several AYA developmental considerations. First, as we know, cancer diagnosis can disrupt independence. And so when I think about the communication patterns, we don't have the traditional patient-doctor dyad always. If there was a young adult that went to college and had to come back home for their cancer care, then that parent may be in those discussions about what should be done for their health promotion, and we need to keep that in mind. Secondly, formation of self-identity includes identification with peers, as we heard. Cancer diagnosis disrupts this. So really there has been shown in the literature the role for peer support to optimize health promotion. Thirdly, there is some literature within survivorship, more so in the childhood cancer survivor population, but this impact of intrusion and avoidance of cancer identity and wanting to re-immerse with healthy peers, and how does that impact if they don't, if they just want to go back and be healthy and not hear about specific things related to their cancer diagnosis and treatment. And fourth, we know that they're a very mobile population, and so as we heard in Karen's talk, they're not necessarily regularly, coming back, but we have to think about if they're not coming back to the cancer center, which the majority aren't, and then there's insurance barriers, or if they can't get access to interactions with their healthcare team to talk about health promotion. And they also have geographic changes because they're moving, they're getting jobs, they're going on to college, and what about where are they seeking their care and accessing it? And all of these factors impact on communicating about their behavioral and lifestyle practices. I also think that we can't not talk about diversity considerations. We've heard about age, teen versus young adult versus older young adult. And in this study that was reviewing the literature on the use of face-to-face support groups, and then also comparing, talking about the emergence of online support, they also highlighted that you really can't assume that an adolescent young adult patient within this broad age range of 15 to 39 are going to necessarily cohere as a group or even benefit from the same type of support. But the one thing in terms of commonality that we do have is the comfort and use of technology. And that, there are studies showing the similar percentages of internet use in both the teens and 20s, and it drops off very slightly towards the 39 age group, but still we have this commonality. We also have to think about cultural considerations. And in Dr. Kent's, as was highlighted yesterday in the AYA HOPE study, they explored the social information needs of adolescent and young adult survivors, and they had two important findings that I thought were very interesting. So Latinos were more likely to report the need to talk about their cancer experience with family and friends. And so I think this is important because the communication dyad, when we're talking about health promotion, do we need to involve more than just the AYA survivor, but do we also need to think about the support of family and friends? Secondly, in the greater than 20 years of age group, they were more likely to report the need of meeting survivors. So the impact of having this peer support and group in possibly the older young adults may be important considerations when we're designing interventions. We also have to think about how we're communicating. Are we doing it in the traditional verbal, doctor-patient, healthcare provider-patient interaction? Are we giving them information through paper, and is that the best method? And then, as we've talked about and seen some of the work with Bernard's work, are there other modes of communication of information through the internet, and thinking about text messaging? Because they're never without their phones, but probably none of us are either. So when we talk about the verbal communication and thinking about the provider-patient dyad, getting back to the question, how can we facilitate this dyad so that they are an active participant in their care during cancer treatment, but also throughout the cancer care continuum as survivors? And highlighting some of Dr. Zebrack's work, because he always does wonderful work, and I thought that this was a very important study kind of thinking about communication. So he did an in-depth qualitative study with focus groups and young adults who participated in a camp, and he was asking, what helps and what hurts in terms of words and actions for our survivors. And summarizing briefly a couple of domains that I thought were very important and insightful about how we communicate with our teen and young adult patient is when in the information domain, what's helpful is if you're answering questions, and what's hurtful is if you're fact-telling or delivering in a patronizing manner. So if you're in that survivorship visit and you're talking about, well, you need to exercise, you need to stop smoking, and just in a very patronizing fashion, you're probably not going to get anywhere in terms of having an effective communication about healthy lifestyles. In terms of the interpersonal and social support domain, what's helpful is positive attention, feeling more like a normal person, again, that identity of normalcy and getting back on with life. Hurtful is denying or dismissing their feelings or experiences. And so many times when I talk in our survivorship clinic discussing about the need for maintaining a healthy body weight and regular physical activity or eating healthy, they say, why are you coming at me with all of this information? Isn't that important for everybody who's in the United States? Aren't we an obese population? But putting it into the context and saying, yes, we all need to do a good job at that, but there may have been specific treatment exposures that are going to put you at risk where your heart could have possibly some late effect, and having a strong, healthy heart through regular exercise and through healthy eating can even be more important. And other people your age may not really have had the same experience and really appreciate the importance of these variables that we can control. In terms of paper communication, through our Livestrong Centers of Excellence Network, we completed a study of survivors, and this also included pediatric cancer survivors, but adolescent and young adults. And we recruited from the 7 Centers of Excellence network site, and they completed a self-report survey on the receipt of survivorship care planning and confidence in managing their survivorship care. I wanted to highlight the demographics of this population because I think it's really important. At the top, these are high using survivors. So 71% were going to oncology or survivorship clinics. So again, this is not reaching the general population at large. It's not surprising from where we recruited from. And then when we asked the frequency of visits to an oncology or survivorship clinic, 48% were going more than once a year. So again, high users. And I was thinking about some of the discussions yesterday about all of the things all the different specialties that we give them. Then we asked them, has the doctor discussed later chronic effects of treatment? And 77% said yes. I think in the context of this information, should have this been 100, but what they reported is that they heard these discussions, 77% heard these discussions. And then looking at some of what we think are quality indicators for survivorship care, do you have copies of your medical records? 66% said they did. Do you have a written treatment summary? 51% said they did, because again, knowing what treatments they got is very important to say, what is your cardiac risk factors? Having a written survivorship care plan, and at the time this study was done, only 43% reported having this, and this was within our network. And then having all 3 items in their possession was only about a quarter, so not having this written information. Then we took a look, and in our logistic regression analysis, we were trying to look at factors that would predict low confidence in being able to report that they could actively manage their survivorship care. And 2 important factors came out. Being a minority had a 2.29 odds of reporting membership in the low confidence group for managing their survivorship care, and having a follow-up survivorship care plan. If you did not possess this document, you had a 2.65 odds ratio for reporting low confidence in navigating their survivorship care. So we concluded that lacking this survivorship care plan, a written form of communication is associated with a higher odds of being in a low confidence group. So they seem to somehow prepare survivors to be more self-assured in being their own health advocates. And things that can be included are diet and exercise recommendations and talking about things such as tobacco and if there's opportunities for different programs, and having that recorded may be effective within the survivorship care plan. Ethnic minorities were also a high-risk group for low confidence in managing their survivorship care. And so really, again, just like Karen discussed, we need to have interventions that are going to improve receipt of survivorship care plans, but in diverse populations of young adult survivors. And as I was preparing for this talk, I think we also have to think about particular opportunities for research and how can we explore how these written forms of communication may not only improve the doctor-patient communication about health promoting activities and other aspects of their survivorship care, but also it can possibly provide opportunities to study how it can affect doctor-doctor communication, because again, the AYA population is mobile and they may be interfacing with different healthcare settings. So say they took that survivorship care plan and it had recommendations, they can go to that next doctor and say, I do need to be worried about, my heart health because of this treatment exposure. And many times survivors say, it's so exhausting to have to tell my story over again when I don't necessarily think that next doctor is interested. So again, looking for this for future research. And then I thought I would end by just giving two examples. These are work in progress and it's not published data yet, but how can we as healthcare providers communicate better with the AYA population to maximize their health promoting behaviors across the cancer care continuum? And I wanted to kind of highlight some of my interpretation of how to address the diversity issues, both from an age perspective as well as interventions that are culturally appropriate, as well as modes of delivery for interventions. So we have a project that's a community academic partnership, and we talked a little bit about CBPR research yesterday. And I've been a long-standing volunteer for an organization that was started in Los Angeles, actually at Children's Hospital Los Angeles 20 years ago, called Padres contra el Cáncer, or Parents Against Cancer. It was actually formed by parents who felt that they had children who were diagnosed at either 21 years or less, and they didn't feel they were getting the health information that they needed within the Latino community for various reasons, including language. And I've had a long-standing relationship with them, and we talked about what were gaps in their portfolio of services. And over the course of 10 years, we've recognized that addressing issues to teen and young adult cancer patients and survivors is important, as well as the survivorship realm, because they initially had focused on different things such as time of diagnosis and monetary needs, and kind of moving into other areas for their portfolio. So we began our research activities a few years ago when I conducted a qualitative research study to try to understand barriers and facilitators to survivorship care for Latino adolescent and young adult survivors. We completed key informant interviews with teen and young adult survivors up to the age of 39, and we also did parent focus groups. The initial study did not have parents included, but even people who were 35 said they still go back to their family members to help guide them on the type of care that they need, because it can be very overwhelming. And some of the major themes that arose were that facilitators to survivorship care included that it's really critical to include the nuclear family in survivorship care discussions, that it's helpful to have family members there to help you understand what you need to do to stay healthy. Barriers to survivorship care included cancer stigma associated with survivorship care discussions. So they would go back, what did you do to get cancer as a young person? Was it because there was smoking in the home, not enough belief in God? A lot of blame came back, and they said that there was this continual emotional distress regarding their cancer diagnosis when it was brought up again. So they said, as a Latino community, many times we have a very close family network, but we may have a lot of blame outside from extended family members. So sometimes it was hard to talk about cancer experience. We just wanted to put it behind us. So we found this data and we said, but is there validation in the community? And Padres, they do a lot of needs assessment for the communities that they serve. And now they're as far out as Florida, Texas and in different communities, and they assessed their client population. And I said, does this resonate if we're starting to think about what we can do in terms of survivorship care? And they went back to what they their collection of data through their needs assessment, and they said that we did validate our findings. So there was an opportunity through the National Cancer Institute and the Center to Reduce Cancer Health Disparities, and it was a feasibility study for a collaborative minority serving institution and a NCI designated cancer center to establish a collaborative partnership. And I share this story because Padres met that criteria by being a nonprofit serving the Latino community primarily, and we were an NCI designated cancer center, and we had ongoing discussions with the Center to Reduce Cancer Health Disparities. Did we fit? Because kind of some of the more traditional models were medical schools, minority medical schools, and NCI designated cancer centers. But we were able to apply for the grant, and our focus for this grant was the research infrastructure building that was needed within the community to begin to say, how can we do research in the community setting? It really is an equal partnership between academic and community partners. I'm the PI on our side. The CEO at Padres is the PI, and the money gets distributed completely equally. And that research infrastructure of doing NIH progress reports and all of that, I highlight that because that's been an important learning opportunity for us. We had to go through and educate their whole staff on what is IRB. They had never heard any of the issues about Tuskegee and why we have to have these informed consents in place. And it was really an important opportunity for learning, and then also vice versa on our side in terms of how do we make culturally relevant recruitment materials. So it's really been a wonderful partnership. And as the second part of our project, a pilot study that was embedded within this was the development of a culturally relevant educational intervention for Latino adolescent and young adult cancer survivors that we're going to deliver in the community setting. So in preparation for our intervention, we completed 4 community advisory group meetings, all in the community setting. We both recruited, and we would invite the teen or young adult, and then they were able to invite whoever they also thought was important as part of the cancer, part of their cancer care. So they could invite parents, siblings, boyfriends, spouses, extended family members, and we did it in Spanish and English. And basically what we did was we had these open-ended questions. We knew the domains that we wanted to educate our survivor community about in terms of risk for future health problems, need to know what treatment you were exposed to, survivorship care plans and the need for this. And we also had to put in another important component because so much of we face a lot of this in California, but the need for continuous health insurance coverage and a domain of what is health insurance, because if we're educating about them about their survivorship needs, but then the community really felt if we're not telling them how we can get access to that care, then we shouldn't be trying to educate them about this. So when we conducted these community advisory groups that really were committed for a year, this was a very empowered group who wanted to give back. So it wasn't, we're now at the phase where, and I'll talk about that, but we're going to be doing the intervention to test for its effectiveness. But we started with an empowered group who wanted to talk about their survivorship care experience. But when we got back into the groups, it got back into these discussions about avoidance of survivorship discussions because it negatively affects the teen and young adult survivor self-esteem. And they said, why do you want to talk about cancer again? We finally got our hair back. We don't have our puffy faces from the steroids. We just want to put this behind us, and we want to move on from this cancer experience. However, when we gave them examples about, well, you need care, it doesn't stop at end of treatment, and we gave them examples of different templates of survivorship care plans, they said, this would be helpful in navigating our care because then we wouldn't have to keep repeating our story to the different providers because we're not followed in the cancer center consistently. Lack of health insurance was a significant source of stress because it prohibits access to our care and interactions with providers. They say, you may say, well, my provider says you're going to do X, Y, and Z, but you can't come back because you might be, it was specific to our LA community, but you age out of the public health insurance plan at age 21. Which many of them had. And then we have to remember to address language barriers and remember low literacy. And they said, we get lots of handouts about what we should be doing in the oncology clinic, but at the same time, it can sometimes be so dense in information we don't understand it, and we're respectful and we don't want to bother our provider with further questions. So this is where we're at. We've decided to do a fotonovela as our health education intervention. It's been done in the pediatric community for asthma. It's been done in the adult population for renal disease, and it's been effective in minority populations. So we wrote our script on these different educational domains based on our community advisory group majors themes. We had a lot of fun with it. We were able to do an actor read through because of the connections that Padres has with the community members, and so we were able to stage play on what could be questions raised when we were delivering the health education material. And again, something that we would not have been able to accomplish with our grant funding, but they have in-kind support from a Pixar animator that they use in the majority of their health education materials. And I don't know if I could show this, but this is Esperanza, and she is a 9-year-old childhood cancer survivor, and they use her as kind of, it's been well validated for all their health education materials, and Esperanza means hope, and their main focus is where there is life, there is hope. So she couldn't be aged because she is their character and that can't be moved. So we had to talk about how can we expand the intervention. But Angelica, she's the teenage sister. And so we said, let's build characters with that. And so we developed a storyline of Angelica's friend, who she has in high school. He has a cough. He is a lymphoma survivor. And wants to play soccer, but doesn't want to tell his parents about their concern about needing to go back to the doctor's office, and wants to be more normal like his peers. So we have these different pieces. And so we're testing that right now within our community. And just for the purposes of time, I'll skip our second study. But I think that there are a few things that I want to summarize at the end. So what may help work to help communicate better with the AYA population in discussing health promotion across the care continuum is I think we need to really emphasize survivor empowerment through doctor-patient communication and considering the survivorship care plan as a tool. We need to think about these innovative health education materials that are both age appropriate. You know, perhaps our fotonovela with a high school student being a cancer survivor is not going to be relevant in a 28-year-old, but we have to think about also cultural relevance and diverse modes of communication, whether it be the internet or cell phones. And then how can we enable access to these interventions across the cancer care continuum in terms of being a mobile population and these insurance factors. So really needing to think about community options for low cost, but accessible and attractive interventions. And so even at the end of our grant with our Padres partnership, we've talked about, you know, they're going to also have a tool. We're going to evaluate it for its effectiveness, but it's something that they can continue to deliver in other communities. Thank you.